It is my pleasure to introduce Dr. Kelly Agnew, orthopedic surgeon, physician executive administrator of Tri-Rivers Musculoskeletal Centers, who's going to talk to us regarding the joint replacement option. Please help me in welcoming Dr. Agnew.
Thanks a lot.
And this is your slide.
Well, good afternoon. It's nice to see everyone out on a day like this, and I'm going to adjust this down in case I am too loud. It's been adjusted, I'm told. Well, thanks for coming out on this beautiful afternoon to talk about something that affects all of us in one way or another. I'm the talk nobody wants to hear because we'd like to think that we can always manage our arthritis conservatively, and we'll talk a little more about that, of course. Once in a while, though, we get to the end of the road and the surgeon's help may be needed. Never in a rush. That's why, when I was thinking about this talk, I wanted to call it, not only why would you get it done or how would we do it, but when. That's very important if you're someone struggling with these diseases. Now, I've been around for about 24 years in private practice here in the North Hills, and then more recently in a joint venture with UPMC. And what I do in general is hip and knee replacement and some knee arthroscopy. So I thought, as we talk a little bit about timing of replacements and the concept of replacement, we'd talk about a little basic review. We'd talk about some conservative options because there are some real hot button options out there today that we wanted to talk about a little bit. And then we'd talk about a replacement only as a last ditch effort if everything else fails us. And we'll look at some implants together as we talk about that. Well, arthritis tends to be the leading cause of disability in the United States economically. Over 54 million people and 300,000 children are affected by these diseases. 21% of adults at some time get a physician-directed diagnosis of arthritis. And it's economically very costly if we think about lost wages of arthritis sufferers and the medical bills of arthritis sufferers, over $100 billion. Now, arthritis, I think, could be known as an equal opportunity offender. It could not care less how old you are. It doesn't care what you do for a living. It might care a little bit about your family history. We think some of this is genetic, but it doesn't really seem to care about your body weight or your socioeconomic status. It loves to affect everyone and any joint. We most typically treat hips, knees, shoulders, and fingers as the more disabling joints that we can do something for. And from an osteoarthritis standpoint or degenerative arthritis, we're really looking at the wear and tear of a lifetime in most people. Sometimes there's an injury, a sports injury in adolescence, a motor vehicle accident in our 20s, but 99% of the time it's good old-fashioned wear and tear influenced by our genetics, what we inherited from our folks. Now, most of us in this room have some of these things. We know that we're getting a joint pain, swelling, and stiffness, and we know as they progress, we'll get some warmth, some enlargement, some loss of mobility or stiffness, and some crackling. And the reason for this is not only mechanical, but inflammatory. As things wear, our body responds to them. You may have a knee that once in a while will swell up or swell out in the back because your knee lining, the synovium, says, gee, this thing is rough. I'd like to lubricate it some more. I'm going to make extra fluid, and it can pooch out anywhere, particularly in the back of the knee. The warmth is also from inflammation, and the crackling, called crepitance, is just two rough surfaces sliding together. Now, when we think about, I'm not sure if I have a pointer here, but when we think about arthritis and we look at x-rays in the office, normal joints have a space when we're standing up. There's the end of the thigh bone, the top of the bone of the leg, the tibia, and in between is the cartilage, the padding that allows us to move smoothly. When I take an x-ray of an arthritic knee, I see several things. I see loss of that space. So when your doctor says you have bone against bone arthritis, we're really talking about loss of that cartilage space. I see some thickening or whitening of bone called sclerosis, and some bone spurs that look like bird beaks sticking off the sides. And if I saw this person in the office, I'd say you have end-stage arthritis, about as bad as it gets. Similarly, if we look at the hip, we might see some normal anatomy where there's a nice round ball in a nice round socket with a space in the middle. Or if we go to our hip on the left, there's no space left at all. It looks whitened where it's wearing and thickening. There are even some little soap bubbly cysts on that hip. This would similarly be an end-of-the-road hip, end-stage arthritis. Well, we would never meet you in the office and say, well, you've had arthritic pain for a couple of months, let's run off to the operating room now and do a joint replacement. That's not reasonable. If anyone has given you that advice without conservative care, get up and run. But we always ask people to go through thorough conservative treatment for several reasons. One is, it works. It may work for a number of years, it may work for a number of months, but no matter how long it works, if it improves pain and improves quality of life, it lets our patients live their lives without the risks of surgery. And we never want to forget about the risks of the things we do. We ask them to start with medications. You heard a talk about physical therapy, which I use before and after and as an alternative to joint replacement. We encourage our patients to carry canes or walking sticks, which brings about another art form all to itself. There's some pretty cool canes out there. And we'll talk a little bit later about other injectable therapies, joint fluid therapy, about good old-fashioned cortisone, which is really a little different now than it was when it was invented. And we'll talk a little bit about some more controversial or newer injection therapies. So almost all of us, if we have a headache or a backache, if we can, run to our go-to anti-inflammatories. They might be Advil or Aleve or something by prescription, and they are fairly safe for most people. But we have to remember that the reason we tell our primary care doctors that we're on these medicines twice a year to have our blood checked is there's a rare chance they could harm our kidneys or our liver. They can give us some stomach upset, and some of them have even been linked to some heart attack concerns. Rare but reported for most anti-inflammatories. Unfortunately, many of my patients are on blood thinners. There's a tremendous need these days for blood thinning agents, and these sorts of medicines aren't acceptable for most patients on blood thinners. And we know that good old-fashioned Tylenol just doesn't work as well. It's safe for people on blood thinners most of the time, and it's kinder to our stomachs, but it doesn't seem very effective. So that leads people to look at other things. Well, if I can't get relief with something over the counter or even my prescription anti-inflammatory, what else could I use? There are several supplements, and you may be able to list 10 different anti-inflammatory supplements and things that we see in the health food store, but the most studied supplements are good old-fashioned glucosamine and chondroitin. They seem safe. We're not sure exactly how they work. I know that some of the manufacturers say, rebuild your cartilage. Well, I don't know. I'm not sure that feeding us cartilage building blocks builds cartilage, because I've eaten enough roast beef, I should look like Arnold Schwarzenegger, right? I'm not sure that it really builds cartilage, but it helps a lot of people. So I definitely support the use of these. If you want to try a supplement, the best thing to do is to go to a big store and see what's on sale, because chemically they're the same, and to get them with a fancier label for 3 times the money seems awful. And many of my patients say they help them a lot, so I would support anything that helps someone that's safe. Well, what about shots? You know, when I was coming through training many years ago, we were in an era where steroid shots like cortisone had been very popular. And then they were misused, mostly in the National Basketball Association, to keep injured players playing and harming them terribly. And everyone got the idea, boy, these aren't safe. Well, if you have a joint that looks like those x-rays we looked at a few minutes ago, I don't think you can harm it very much. And we think that if you space your injections, you know, if they're 3 or 4 months between, it's probably a relatively safe treatment. It has an anti-inflammatory, methylprednisolone, the cousin of old-time cortisone. Mix in a little lidocaine or a local anesthetic like your dentist would use, and it's fairly comfortable. But we always warn our diabetic patients that steroid injections, even into the knee, the shoulder, or the hip, can really bump up that next couple of glucose readings, sometimes for 12 to 24 hours. We don't think that it's dangerous, but it's pretty frightening if you're a well-controlled diabetic patient and you go home and something's jumped 75 or 100 points on you. It can be very scary, but it doesn't last. It's a short-term side effect. Well, these days we do an awful lot of lubrication of joints. also called viscosupplementation. Someone about 30 years ago in Europe decided to scalp a rooster. I don't know why. Who would ever think that there was a human joint lubricant living in a rooster's comb? But that's where they found it. I just don't know what was going through this person's head, but that's where they found it. And they were able to crush it and refine it and sell it to us to inject joints. I've been performing these injections for about 25 years, and they help some people. There's good news now. We don't have to scalp roosters. The chemicals, which are hyaluronic acid derivatives, can be made in the laboratory, and that's kind of good news. Because before, if you had a sensitivity to feathers, or an allergy to chicken, or an allergy to eggs, you couldn't get these injections. But now that they're manufactured, they seem safe for people with egg and chicken allergies. We're not aware of any all-over-your-body side effects from these, but some people get inflamed knees from them that can cause a little local warmth and discomfort. Now, the problem with this treatment, like every other medical treatment I've ever seen, is it's variable. You'll know someone who swears by these. They'll go get these every 6 months. They'll say they're the best thing since sliced bread, and I believe that person. And you'll find someone else who said that was a waste of time. I had those shots and they didn't help me a bit. I believe that person too. Our bodies respond differently to all medical treatments, surgical and non-surgical. So we know that this just doesn't help everyone. I encourage people to try it once. If it helps, you win big. If it doesn't really help, we don't think there's a downside or a real risk to them. Now we're going into brand newer science issues that people ask me about in the office all the time. There are some fancy injections called PRP, or platelet-rich plasma, that are used a lot in the athletic injury community. This season, I guarantee if you pay attention to the news, there'll be at least 2 or 3 Steelers who injure their hamstrings, and the doctors who take care of them will inject some PRP to stimulate the hamstrings to heal faster, they think. They've got pretty good information on soft tissue healing. It's often used for some elbow tendonitis conditions, used for hamstrings injuries, particularly in the NFL, and sometimes people use them to see if they'll help arthritis pain. So one of my partners does this for some sports injuries, but not arthritis, and we've been reading up on it to see how could it possibly help a worn knee. Well, some papers say that maybe it just slows down that inflammation process like the cortisone shot does. Other people say, well, you know, these are blood products that are spun down that have all kinds of neat chemicals that belong to you, the patient, in them. Maybe it stimulates the cartilage to heal a little bit. Or maybe it increases lubrication production naturally. But those are all theories. The truth of the matter is nobody's 100% sure what these do in the arthritic knee. Since it's the patient's own blood products that are spun down, it's probably safe. We just don't know what it's doing. I don't think there's any danger to it. And some patients have told me they worked. Other patients have told me they haven't. Most commercial insurance plans will not cover these injections. Some will. We don't usually do them for arthritis, but if our patients are really looking for alternatives, we'll help them find someone who will. Just the jury's out on this. We need some higher quality research to be able to assure you that they work, but we can assure you that they're not dangerous. Now, this is the really controversial new arthritis injection that's been used for several years. The stem cells are cells that live in our bodies, often taken from our bone marrow or our fatty tissue, that don't know what they're supposed to be yet. They're young, immature cells. Think of them as your 12-year-old nephew who wants to be an astronaut one day and a firefighter the next. These cells haven't been chemically turned on to their final destination. They're not sure what they're supposed to be when they grow up. And the neat thing about these cells is they can turn into just about anything. And the question is, could they turn into a cartilage healing or building cell? We're not sure. They may. The real problem here is that there's fairly limited research. Meaningful research on a treatment like this would require thousands and thousands of people to have the same treatment and some to have a placebo treatment, and it would compare them. And that's not quite out yet. It will be someday. They're very expensive, and I've heard people say the same things. I've had people try them. One of my partners tried them. He's a physical medicine doctor. He's not a surgeon. He's a very active person with terrible knees. And he swears by them. He had to go to New Mexico to get his. He thinks they're amazing. He can't tell you enough about them. But I've had other patients go and come back and say, well, wait a minute, that was $5,000, and I don't feel any better. And so there are some less expensive ones that are still very expensive. Insurance carriers, by and large, are not covering these because they're still considered experimental. Doesn't mean they're dangerous. It just means that the jury is out by way of high-quality research. I hope that something this simple is an answer for some people, but it will take some research before the insurance carriers jump on and say, okay, we'll cover this like we would a medication or a steroid injection or a lubrication injection. Now, many of my patients come in and say, well, can't you just scope me? Can't you do something that's minimally invasive to clean out my arthritis? And this is common. Over 600,000 people have this done every year. Now, the problem is, it's not a guarantee when you have an arthritic knee. In fact, we think that unless you have catching and locking, it may not do much. But this is my much more handsome partner, Bill Abraham, who is doing an arthroscopy there through 3 punctures. Unfortunately, we can't see the monitor he's looking at there in his operating room to smooth the cartilage of someone who he thinks does not need a joint replacement yet. It's not permanent, but it can help some people who are having locking and catching sensations who have some leftover cartilage. Well, oftentimes people come into the office and say, do I have to have a joint replacement? Well, as funny as it sounds, and I don't mean it to sound disrespectful to people with arthritis, but I assure them that it's a diagnosis that's not dangerous and it's not deadly. So if it's not a heart attack, I always tell them we don't have to do anything. But if you get to a point where you're not sleeping well, that's very detrimental to your health, and arthritis can wake us from sleep. If you get to the point that your activity level is limited, maybe you're gaining weight because you can't walk for exercise, maybe you can't do the things you like for fun activity-wise, or if you just wake up one day and it dawns on you that arthritis has compromised your quality of life, then it's time to think about replacement, not before. But when I say quality of life, I'm thinking of 2 ladies that I've treated for, 15 and 10 years each, and recently came in and said, we're getting a hip replacement. I said, I really find that hard to believe because we've been talking about hip replacement since the Carter administration. And what happened in both is very interesting. Both of these ladies are healthy, and one wanted to go see her sister-in-law somewhere on the West Coast, and one had a big vacation plan with her family, and both of these ladies had canceled a trip. Well, that's a big deal. You know, if you wake up and say, I've been looking forward to something, and maybe it doesn't have to be a trip. Maybe you like to go out to dinner with your friends once in a while or go to a movie. If you find yourself saying, oh, count me out, I've got to stay on the couch, that knee's awful. Well, that's what diminished quality of life is. And this is not uncommon. People who have to take the joint replacement option are in good company. About 700,000 knees a year, over 300,000 hips a year in the United States. Because the baby boomers are wearing out their joints at amazingly rapid rates, by 2030, the fear is that 3 million replacements will be needed each year in the US and 600,000 hips, and they're not quite sure they've trained enough joint surgeons to handle that at this time, but it's coming. Now, replacement should have been called resurfacing. The hip procedures started with partial hip replacements in the late 50s for broken hips and evolved from there. The knee procedures came along more in the late 60s, early 70s and have evolved from there. But when we think about what we envision as a replacement, I always thought before this training that you cut a big hunk out of someone and put a kind of a $6 million man mechanical thing in there. But really, on the knee side, at the thigh bone, we're just shaving away enough bone and damaged cartilage to accommodate an implant that looks like this, that looks like your thigh bone from the end, whether you're looking from the side or the front. We're shaving away just enough of your tibia, your leg bone, to accommodate this plate and its stem. Your cartilage is actually replaced by a dense plastic, and your own muscles and tendons hold it together and allow it to move. The kneecap stays in place, but underneath the kneecap is a little high-density plastic button that rides in this groove They're all here for everybody to take a look at. These are trials, but the weight and the feel are just like a real implant. They're made out of a lot of different things that have been studied for durability. On the leg bone side, it's usually titanium. The plastics are called high-density cross-linked polyethylene. Most of the metals are at the thigh bone are either titanium or cobalt chromium. This example is my favorite. It's a ceramic called zirconium that holds up a little better. I put this usually in my people in their 40s and 50s, active people in their 60s and 70s who I know are going to be out there playing 18 holes and not just playing bridge with their new knee. So there's nothing wrong with bridge. That wasn't an anti-bridge comment. But the joints need to be based on our kind of our life story, what we need from them. We can correct deformities, we can restore mobility, and if you talk to people 10 years later, most of them are still happy, 92 to 94% 10-year success rates that taper over 20 years. But what we can't explain is that person you've met, and I want you to think about that person, we're going to talk about another group of people, that person you've met who said, I hate my knee, I just hate it. And we've all met that person. I've met that person. I've done that surgery. And I can't figure out why, because right away, about 99% of people, after their 3 months of recovery, are very happy with their knees. And I'm kind of a superstitious surgeon. I use the same room, the same implants, the same assistant, the same staff, every week, every week, every week. So what changed? All that changed is biology, the different makeup of different humans. And we can't tell you why. We've all met the person who says, I just don't like it. It doesn't feel natural. I don't know why, because 99 of their neighbors may say, I love it. It feels close enough to natural for me. But the long-term success rates look good. The hip is similar, but it's a little more difficult to put the new ball and the new socket in place. The new socket is ordinarily made out of titanium, and it goes into your own shaped socket. And the replacement for cartilage, again plastic, fits into it. On the thigh bone side, we can't just stick a ball on there. People tried screwing them on, cementing them on. The best way to get the ball to stay is to put a stem inside the bone. This is a stem made out of cobalt chromium, manufactured in Memphis, Tennessee. That's my personal favorite. Do brands matter? They matter to me. This one's never had a recall. But, hallelujah. But if you think about it, if you have other implants that have never had a recall, probably the best brand for you is the brand that your surgeon knows how to put in just right. I never tell my mechanic what brand of oil to use. What would I know? He says, should I use the best? I use the best, Joe, because I think it's the one the surgeon knows how to put in just right. I feel the same way about how you get into the hip. There are about 5 very well accepted approaches to get into the hip for implants. They all have ups and downs, but at the end of the day, the results at 6 months, 12 months, 24 months are identical. So I always tell my patients, I think that I never tell my mechanic exactly how to get into the engine to get to my carburetor if my car has one, I don't even know. But I would say, can you just get in there and get that thing fixed? And that's the way to think of your surgeon. If you trust your surgeon, they know one of those 5 doorways that'll take them into your hip and get it done. Well, to get back on track, all we have now is a stem sticking out of our thigh bone. We have to put a ball on it. And they're made out of either cobalt chromium, or this one again is that zirconium. And they actually attach to the stem without screwing on. These are machined so beautifully that they cold weld. You actually hit them with a little hammer. And then when we put the hip back in socket, the ball is in its socket. It normally has much better mobility than you did the day before. The surgeon makes it stable, that is unlikely to come out of the socket, by the way the pieces are oriented and by the way your tissues are tensioned. And I think they should have called it resurfacing. Again, these are relatively small devices that serve even large people. I'm trying to watch time a little bit. So what we're looking for is a return to a higher quality of life. When we say normal activities, most people are not going to go out and play baseball like Bo Jackson did on 2 total hips. But we have people who bowl and hunt and fish, and people who do a variety of activities. A lot of my patients up north like to kayak. They like to ride motorcycles and all-terrain vehicles. And the only things I ask my patients not to do on these implants, and I'm not joking, I ask them not to run or jump. I gave up running and jumping a long time ago, and so did most of my patients. So it's not a hardship to say, hey, you just can't go out and do the 2.5K race with your granddaughter. You can't do that. The joints aren't made for it. But I don't give them any other restrictions now because the implant quality is such that unless your bone quality is poor, and we have to restrict you because you have very bad bone quality, I don't restrict people because they have an implant. So I told you that we never want to get too excited talking about benefits without talking about risks. And to be as honest as we can about those, these are the big ones. Infection in the United States happens to about 1% of joint implantation patients. I'm fortunate enough to do my joints in a hospital where it runs about 1/8 of that, so we're way lower than 1%. But it's important to prevent that. It's a bad complication. We prevent with IV antibiotics and by stopping the operation every few minutes and just washing some antibiotic fluid through. So patience on the part of the surgeon helps prevent infection. We worry about dislocations, particularly of the knee, I misspoke entirely, particularly of the hip, of the ball coming out of the socket. We spoke a little to that we have to work on aligning it by where the pieces are in the skeleton, how tight the soft tissues are, and by admitting to the patient before surgery that your leg may be a little bit longer when we're done to make darn sure it stays in the socket. I would much rather come out and say, you know what, that leg's a little bit longer, but that hip is stable, because I can't come out and say there's good news. The legs are perfect and this thing's going to pop out every 6 weeks. You can't do that. And finally, blood clots are at the top of the worry list for many people. The statistic for blood clots in the United States after joints is about 3 or 4%. While that sounds high, most of them are not terribly painful and don't cause big problems. But we worry about them because a blood clot in the leg can lead to one in the lung. And we usually get around those with injectable blood thinners for a few weeks, good old-fashioned white stockings that everyone dislikes, and by moving patients early. You might visit friends in the hospital now who've just had a replacement, and you walk into the room, they've been out of recovery for 2 hours, and you say, where's Joe? And they say, well, he's in therapy. Because movement trumps all of those other treatments to prevent blood clots. It's better than all the drugs, all the stockings in the world. Getting those muscles moving keeps the blood flowing. Now, when we're thinking about joint replacements these days, it's not just the patient and the surgeon anymore. We've studied this a lot to figure out what makes a successful joint replacement. And it's a huge team. It's the patient and their family or their neighbors, whoever's closest and most supportive to them. Your primary care doctor. Can't say enough about your physical therapist. I always tell my patients, you'll see the therapist 3 times a week for about 2 months. In that time, you'll see me twice. The therapist is really important. They're the front line of helping you recover. The operating room staff, the nursing staff on the floor, all this is what we call success through partnership. It really is a matter of bringing all those people together to make sure that we get a good result. And it's that kind of thinking has led to something called enhanced recovery. We think about therapy before surgery to get people strong. We think about dieting and a little bit of weight loss. Many health insurance carriers in this region demand that you have a body mass index of 40 before getting a joint replacement. Others will allow it to be 45, but the healthiest weight you can have for yourself is the idea. And we like people to manage their diabetes, their cholesterol, their blood pressure. And the hardest thing we have to ask people to do is get into smoking cessation programs. Smokers have more wound problems after these large surgeries, and a wound problem could lead to an infection. Almost every hospital has something it calls a joint camp or an educational session. They're priceless. You learn what's going to happen in the hospital and after. You meet the people who are going to be in physical therapy right beside you in the hospital. It's a really enriching thing. I think we're pretty much we're close to the end of my time, but I'd like to open the floor for questions, and I hope you have a bunch of them. Yes, sir. We're gonna bring you a mic there, I think.
First one, I know several people who had knee replacements. They said they can't kneel. It's just something they can't do. So that's one. Number two is, I read there was a nice article in the Post-Gazette about 2 weeks ago. It wasn't an ad, it was an article. Say orthopedic surgeons like you were doing like cartilage replacement in like large toes, I presume for gout. And if that's the case, do you anticipate that may be an option? It says they're about the size of a pencil eraser. In the future, do you think there'll be something like cartilage replacement in the knees?
Excellent questions. Our first question was, what about kneeling after knee replacement? Many people say they can't. The first answer to that is that many years ago, the implant design would not allow for kneeling. There were sharp edges on the implant that could damage the tendon under your kneecap called the patellar tendon. These days, there are some modifications of the implant. It's hard to see, but there's a dished in or cut out area in this piece of plastic so that when you bend your knee way back, your tendon is actually lying in a cutout area that's smoother and rounded for it. So it is safe to try to kneel on modern implants. Half of my patients say they can kneel fine. The other half say that's too twingy, I'm not going to do it. So it's safe to try, but in many people it's uncomfortable when they press their soft tissues against the implant. It won't harm them, but about half my patients say it's just too uncomfortable, I'm not going to do it. We always encourage people who want to try to kneel to do that on a folded bath towel or a piece of foam rubber. Let's not try it on a hard surface where we can guarantee discomfort. The second question was about cartilage replacement, grafting. In the great toe, there are some grafts that people are using. In the knee of injured athletes, we can put little plugs of cartilage and bone and even grow some cartilage. The problem so far with arthritis is that by the time you're ready for surgical care, you have an x-ray that looks like those we looked at, where you're worn clear through to bone over a large area. Right now, there's no good way to give you a large area of new cartilage. There have been some trials of taking it out of cadavers and planting a big block in there. There have been some trials of taking multiple small pieces that look like a mosaic laid in and see if they'll heal. So far, I don't know if I'd go so far as to call them promising, but I think that the science is interesting and people will pursue growing new parts, because that's the excitement, is what if you could get away from ceramics and metals and plastics and just grow you something new that was biologic. So I think that's a hope for the future. I don't think it will happen in my lifetime, and I know it won't happen in my practice lifetime of probably 15 more years. But it's hopeful. There's nothing big out there yet. Sir?
Stem cell therapy.
Yes, sir.
Do you know if it is now FDA approved?
Wow. I am not 100% sure. I believe that the FDA has approved its use as it can be done. Ordinarily, if the FDA doesn't approve something, you can't walk into a pretty reputable practice and get it. But FDA approval does not infer that it's going to get insurance approval until the research is done. Sometimes, and I'm going to circle back to stem cells, but sometimes we get a little too excited about the FDA. Did you ever wonder why so many medicines get called off the market at about 2 years after the FDA approves them? It's the second look committee. Something can look very safe coming in with preliminary research, and 2 years later, a pretty big committee that my brother-in-law sits on meets. And they look and say, holy heck, look at this research. This isn't safe. And they pull it off the market. So FDA approval doesn't mean it's 100% researched, although it's a good start. But I promised you I'd circle back to stem cells. Although I do not strongly recommend in my practice stem cells because the research isn't quite complete, I don't think there's any danger to them. I've never read anything to suggest they're harmful, but I always warn people that if you're going to go out and spend the cost of a really, really good used car to stick it in your knee, make sure that that's not financially bad for you, because if it doesn't work, it would be awfully disappointing. And the evidence is what I like to call anecdotal. It's a story. Some people say, I felt great. I believe them. I believe they felt great. There's something about their body that responded. And other people say, that was a waste of money. I believe them. It's something about their body that they didn't respond. So I don't tell people, oh no, don't ever try it. If I really believed in it, I'd probably be pushing it. I'd be saying, this is good for you. I haven't seen enough research to give me that comfort level yet, but I don't think it's dangerous.
Thank you.
Yes, sir.
Sir?
Yes, Dr. Abraham replaced my knees and my wife's hip He's a great surgeon, by the way.
I sent my favorite aunt to him. I love that guy.
And he told us both to take antibiotics every time we go to our dentist. And this has been going on for 3 years now. Is this a lifetime sentence?
You guys have the greatest questions. Well, this is a question with two answers. I'm going to give you two different groups of people's feelings on it. There's some more recent research that suggests that that risk of infection from having your gum line scraped, bacteria into the bloodstream, settling in your knee or hip, some of the more recent research suggests that that's very, very unlikely after the first 2 or 3 years. That's led some physicians to say, well, let's use the antibiotic for 2 or 3 years and then you're probably pretty safe. I'm not in that group because I figure there is, to our knowledge, the dose of antibiotic is so small that I can't say there's any danger of that small dose. We're not talking the stronger antibiotics that could lead to developing superbugs or the things that we fear in bad hospital-based infections. So I figure for little cost and little risk, if we're protecting you from being the 1 in a million, I'll buy it. Let's protect you from being the 1 in a million. And these days, a lot of places are allowing those antibiotics to go out as a free service. So it may cost nothing to avoid a small risk, but I'd take them. I'd want to avoid that. The few infections I've treated in my life have been awful things to treat and get people through. Yes, sir.
Last year, I had 2 ruptured discs, and they affected my sciatic nerve. I had the injections in my back. I did physical therapy. Everything was great. I went through your practice, and you guys are the best. Now, my issues are on my left side, when I kneel on my knee, it feels like I'm kneeling in broken glass. Is that going to go away? Is there something we can do to cure that? I've been trying the exercises on my knee, but it's getting better, but it still feels that way.
Well, there are 2 things. The question was, well, what can we do about it, but what could cause it? The 2 things that could cause that, less likely would be that it's still some nerve irritation from the back. That's pretty unlikely. The more likely thing to cause it is some cartilage irritation under the kneecap going down into the patellar tendon. That's the most common cause of terrible pain and cracking and crunching when kneeling. The treatments for that are similar to the treatments we talked about today. The exercises are great, but if they're not working, a trial of an anti-inflammatory injection or a lubrication injection can help. There are some arthroscopic procedures. Unfortunately, our replacements of just the kneecap surface don't work very well alone. It works better when all of the components are replaced. But that's most likely cartilage-based. Ma'am, we have someone in the back.
Could you explain the difference as far as the minimally invasive? How long is that incision in the knee, and what is the regular surgery, that incision, how long is it? And what are the benefits?
Sure. When minimally invasive surgery for the knee came along, many of us with older training were making some pretty darn big incisions. We don't anymore, but we used to make some pretty big incisions because that's how we were taught. Like many medical technologies, that's kind of evolved along. Then we tried to make little tiny incisions and pull them around and stretch them and move the skin and the soft tissues to get to the bone. And that was probably the wrong way to go. We're now in the middle where most of the skin incisions are still around 4 inches, but it's the damage inside that makes it minimally invasive. We're damaging less muscle, damaging less tendon, doing more soft tissue shifting inside. The outside incisions are much shorter because we're better, I think, and our guides are better. We thought that was going to make a huge difference to shrink the incision down as small as you could. And it got to a point of what I like to call diminishing returns. If you got to the point where you had to keep stretching the skin, you'd end up with bruises and healing problems. So you have to make the incision just long enough to get in and do the work, but not longer than you need. That sounds funny, but they're usually about 4 inches now, and that's probably the best we can do. The implant that I use on the thigh bone side alone comes in 12 sizes. This is about the third from the smallest. So to get this in, you can't get it in through a buttonhole, and I always caution people to worry a little more about the outcome they're getting, the x-ray quality they're getting, their ultimate flexion and strength, and a little less about exactly how long the incision is, because I would rather my surgeon made another inch incision to do it just right and see my bones very clearly than try to work in the dark so he could tell his buddies that he made a 3-inch incision. We have to be a little careful making it just as small as we can without harming you. Ma'am, there's someone behind you there.
With the knee replacement, would you be able to go up steps and down?
Well, the question was, what about going up and down the stairs after knee replacement? Going up and down the stairs really comes down to 3 things. One is motion, the ability to move the knee. One is pain, and one is strength. And I might take those kind of out of order. We can definitely give you enough motion to go up and down the stairs, because if you think about it, when you're going down to the next step, there's a good bit of bend. Definitely. We ordinarily can give you enough strength to do it, although some people struggle getting strength back after surgery because they didn't have all of their strength before and we've done a big operation. But if we can give you the motion and give you the strength, the only thing standing in our way would be pain. So we know statistically that in the front of the knee, 25% of people come back and say, you know, I love the inside of the knee, I love the outside of the knee, but in the front of the knee, when I get off the toilet, get out of a low chair, or go down the stairs, it hurts. And then I get to the bottom of the stairs and it stops hurting. We're not exactly sure why. We think it's something mechanical about the kneecap driving deeply into its groove and maybe squishing a little soft tissue on the sides. But about 25% of people claim they have discomfort with that. Doesn't mean they can't do it, but that it's discomfort. So we can give you the motion, most of the time the strength, 75% of the time for comfortable stair climbing. One more question. Anybody for the last question?
This is just a comment. Keeping the
Last
weight
two?
down
That's
is
okay. That's okay.
oh,
That's all right. Go ahead.
keeping your weight down, I think, is primary because, like you said, for every additional pound, you've got a lot of stress on your joints. And that's a big problem for me. I want to keep my weight down.
It is difficult. Fortunately, these days, we get to, we're going to get your question here, though. Don't you give that back. But fortunately, these days, we live in a place that is so medical research rich. I mean, there's a lot going on in Pittsburgh in medicine. And fortunately, newer ways are coming out to help people lose weight who cannot exercise. I didn't believe it. So I decided to test fly a program that comes from UPMC Enterprises called Total Health. It might be Full Health. It's Full Health, I apologize. And it was based on getting me to fix for myself more vegetable-based things, cut way back on the meat servings, grains I've never heard of, and many more salads. And over 3 months, it was about 25 pounds for me without changing exercise patterns. So I encourage people that even if you can't exercise a lot, there are newer nutritional ideas that are real, and they really work for real people. And we're right here in a hotbed of research for things like that. Ma'am.
Are you going to let me? People say that when you have the knee replacement, that when people I've talked to, that they weren't prepared for the pain in that first month compared to the hip replacement, for example.
Right.
And what do you, as a physician, do to help people with the pain management of that?
That's an excellent question. What about the pain that you've heard of, particularly after knees? Well, be a little bit wary of the news programs where someone walks out of the hospital the same day and says they're pain-free. I've never met that person. I've been looking for them. People have different pain responses. Our job is to meet the patient where their body lives and to try to help. And there are several things we do for the knee. One is, the day you come into the hospital, we use a couple of medications. We start people on a good anti-inflammatory called Celebrex, and we even use a little gabapentin to try to kind of confuse the nerves a little bit about pain signals. We oftentimes will give you a little dose of cough syrup because there are certain cough syrups that potentiate pain medicines. Then in addition to your regular anesthetic, we'll put a little nerve block in the thigh, a tiny tube that drips medicine in around the nerve in the front, the femoral nerve, to confuse it. Because a nerve signal that doesn't go up the electrical cord to the brain, you don't feel. And those are the things that we try to do. It's a difficult thing because we're clearly in a country where we never want to send somebody out of a joint replacement with a narcotic addiction. We don't want to do that. But we have to reasonably use opioid medicines. We have to reasonably use our non-opioids, lean on things like nerve blocks, oftentimes some injections inside the knee before we close it up to try to cut down on pain. It's not painless, but from the people I've talked to, comparing 20 years ago to today, we've been able to cut back an awful lot on that discomfort. I wish it was painless, but we're not quite there yet. And I really, really want to meet those people when I see them on the news who swear it didn't hurt. So I haven't found one. Thank you for your time and attention. I really appreciate it.